Thank you, Katrina. Uncompromising and strategic. Wow, that was a great introduction. I really very much appreciate that and really appreciate being here with you today. These are my favorite kind of talks to give to those of you who are doing all the hard work in the sector, in policy development to support the sector, and in research and practice right at the direct service interface. So I hope that my words will resonate today, and let's get going. I would like to start by paying my respects to elders past and present of this, the land of the Mississaugas of the Credit First Nation, the Anishinaabe, the Chippewa of the Haudenosaunee, and the Wendat peoples covered by Treaty 13. I convey my sincere gratitude for the privilege to visit this land today. And I always try to personalize a land acknowledgement. And what I try to do as a researcher is not replicate the stereotyping and bias-inducing ways that we can collect and report data that do harm to Indigenous communities and Indigenous peoples. It is very important, as Katrina said, for us to look upstream at those structural causes and the conditions in which policies and practices over centuries now have harmed Indigenous peoples. So my commitment to reconciliation and good practice is to ensure that when I collect data, I analyze it in a way that is thoughtful and structural, and I mobilize it in a way that is safe and can do good for communities. So today I'd like to start with a few slides that will just set the stage in terms of where I'm coming from. Many of you in the room have done work for years now on TVIC approaches as part of the Knowledge Hub and FACT-funded projects, or SAFAC, PHAC, Public Health Agency of Canada. So we'll really know what we're talking about in terms of TVIC. But for me and my colleagues, and this work represents again, decades of work by a team of us at various institutions, we form this concept of trauma and violence informed care in a specific way. So I want to get you there before I start talking about what we're actually doing with and for the sector to develop new tools and resources. So how many people in the room are feeling some of the things that we've listed on this slide here? I've done a lot of TVIC talks, large and small, over the last while, certainly since COVID and through COVID. And the notion of threats to staff well-being or provider well-being is probably the most significant and important issue that we are seeing. And as I say and have always said, without the direct care workforce, we don't have systems of care. So we really need to attend to staff well-being. And TVIC is very much about safety for everyone involved in care practices and care decisions in organizations that provide care. So we have tried to actually break down and unpack, I guess. I don't like to use too many sort of academic words, but really look at the different ways that these threats can happen. So this diagram, and again, there are two tools listed at the bottom that are freely available. Everything that I will show you today in terms of tools is free, except for the book that Katrina mentioned, because publishers like to make money off books. But vicarious trauma at the top of this diagram is something that comes with your work. If you're working in the gender-based violence sector, supporting survivors or working with those causing harm in relationships, you know that you're going to hear stories of the worst of humanity. So in some ways, when I present this into this sector, people go, "Oh yeah, we do that." You know, most of us have good EAPs, not all, but most have ways that our organization supports us through vicarious trauma. But then we get at issues that are a little more nuanced. Things like moral distress, things like knowing what you should be doing for a client or survivor, but not being able to do that, either because the organization does not allow you the time and resources to do it, again, because they are often strained and stretched, or because the broader systems don't provide those pathways for survivors. And that will wear on you, and that will cause distress and harm as well, especially when it's happening day after day. Then we talk about structural distress, and that's sort of direct harm that can come to the workforce through things like workplace violence and not having your organization properly address workplace violence. And again, I'm not blaming organizational leaders. In fact, with TVIC, we don't name, shame, blame anyone. These are the systems and structures that are set up around us that allow us or don't allow us to do our work in good ways. So structural distress can be these direct threats, just ridiculous work hours, forced overtime, not appropriate work-life balance, and things like that. And then this sort of newer concept that we've been talking about, vicarious structural violence. So this is when you might be on the phone, you're with your client, and you're trying to get them some service in mental health or substance use, and you are hearing how maybe the person at the other end is being very problematic in how they're referring to your client. And they are experiencing basically structural violence through the phone line. And you are witness to that. You are witness to the barriers that people are facing, often because of their intersecting social locations and positionings that is beyond any of your control. But again, witnessing that and experiencing that, it's not hearing the direct trauma, but it's hearing about the structural violence that is affecting your clients. So we are working on this. I actually have a doctoral student who is looking at how to develop an intervention that can support providers who are experiencing these threats to their well-being and what an organization can do to actually remedy that. Because I would say, as one of a study I did a few years ago, as one of the EVs said, and this is a direct quote, so I'm allowed to say it. There's not enough fucking tea in the world that's going to fix the patriarchy right now. So it is not about self-care. That's a direct quote, and I apologize. You know, it is not about yoga rooms and, taking breaks when they don't give you a break, right? When there is no opportunity for a break. So I'd just like to put that out there because that is really a core thing. And all of those things lead to what is colloquially called burnout. But as Colleen Barco would say, really it's being used up. It's the system using you up. It is not a personal failing to go through all of these things and have nothing left. So I think the concept of depletion or being used up is probably a lot more relevant and true than the idea of burnout. So I was saying to Marlene a few minutes ago, I'd like to shift language a little bit and get us thinking and speaking in ways that are more trauma and violence informed, but also don't leave, don't situate people in the minds, especially of those making decisions, in ways that can be harmful, which is why you don't hear me say frontline. You guys can call yourselves frontline, absolutely badge of honor. But frontline came from World War I, where they sent the frontline to be cannon fodder. And yes, during COVID, they did send you to be cannon fodder, and they sent nurses and so on. But let's not talk about people that we value and respect in those ways. So again, you can talk about yourself that way, fantastic, full respect. You won't hear me doing that, and I hope your managers don't do that as well, because that would not be TVIC language. Anyway, I'm probably already behind in my timing. The other important concept here is we position trauma and violence informed care, or TVIC or TVIC, however you like to say it. As long as you include the V, I'm happy. As part of what we call equity oriented care. So it is, and what I'm going to try to do is convince you why that V is so important, even though I know many of you are already on side with that. The V is the door through which these other key concepts or key dimensions of equity oriented care come through, especially anti racism and cultural safety and humility, and substance use health and harm reduction. And this is through decades of research, sort of understanding the intersection of these things and how we can improve practice by integrating these concepts into the way we both develop structures and policies at the practice level, but also those individual interactions. And I know part of those threats to staff well-being is these problems are so big. How am I, as an individual, interacting with this survivor, the fifth woman I've seen today? How am I going to change anything? Well, what I'm going to tell you is that the way that you interact with that woman in that moment is part of the change. You are part of the intervention. Where's Margaret McPherson? Margaret always says you're part of the intervention in that moment right there. So, and that is a really important thing. So you do have a key role. Then we have strategies to articulate equity-oriented care, to actually tailor it to context. And what we found over all of this research and implementation work is that these principles are quite flexible, and they do work really well in different sectors because we've tried to keep things relatively simple and extremely simple by academic standards. So this is part of the evidence base. I mentioned Equip Healthcare. So this is where the equity-oriented work has derived from. And I'd like to think I've taken a key role in bringing that out of healthcare and into social service sectors, including the gender-based violence sector. But we've tested some of this in primary healthcare, emergency departments. The Pathways Project was specific to substance use health and really supporting, people who are facing substance use stigma. As I'll talk about in a moment, it's often the stigma that does the harm, not necessarily the substances themselves, and that's a complex interaction. And again, thank you to the Public Health Agency of Canada, as well as Canadian Institutes of Health Research and the Social Sciences and Humanities Research Council, whose logo I forgot to put on here, for funding for various parts of this work. Some of you yesterday might have heard Marilyn Ford-Gilbo speak about the iHeal interventions. So there's a nurse-led intervention, but also an app. Those are founded on trauma and violence-informed care and the equity-oriented care principles I just mentioned. And then we've done work at Western in a community university. We call it an incubator. We called it a consortium of disruptive women, but then we let a couple of men in. So we changed the name. But we've done research and we post resources on that website as well. So there's an evidence base for this. So let's start with being trauma informed. And again, shout out to those in the room. I see Lorraine and Nancy who've done lots of work on trauma informed practice for decades. This is building on that work. And for example, the work of SAMHSA in the US that looked at the intersection of women's experiences of partner violence and in that case, alcohol, but other substance use as well. So I don't have to tell you in the room what trauma is. It is experiences and their ongoing effects that overwhelm. So it's more than stress. These are overwhelming experiences. And the point is they are anticipatable. Okay. So again, bringing it back to that practice moment, we can understand that those traumatic experiences that are both in the past and ongoing will be present in that interaction. Okay. And I'll tell you a few ways that that will show up. But again, I think that I'm speaking to a very knowledgeable audience. Trauma can be acute from a single event or episode, or the forms that we deal with here in this room, often chronic and complex. And that will perhaps overwhelm both in the moment and ongoing, and lead to different sorts of responses. So we hear fight, flight, freeze, and fawn as ways that it can show up. And I would also stress, and if you think about your own responses to immediately threatening events, sometimes you might respond in a fight mode and other times in a flight mode. So even within an individual, that response might differ and might depend on the circumstances of the day. Trauma is common. So that's all this slide is going to say. The World Report on Global Mental Health Survey showed many of these countries in the red zone. A very similar survey in Canada would have put us in the red zone as well. 76% of Canadians who responded to this large survey would be in the range of having experienced trauma that would lead to post-traumatic stress disorder. So direct experiences, and then if we think of vicarious trauma and the circles around us, we know that pretty much everyone has had direct or indirect experiences of trauma. And here are some examples. I've bolded the ones that are more directly relevant in terms of the sorts of work that you do, but they are both interpersonal and situational. The point I like to make with this slide is that those things that the circle at the right is you can be in situations that put you at higher risk of interpersonal trauma. So I think of the example of people who are leaving war-torn countries, spending years in refugee camps. And we know that refugee camps have increased risks of sexual violence for women and children. And then perhaps you get a chance to come to Canada, and the process of being, for example, a government-assisted refugee is itself highly traumatizing. And then you might arrive and be racialized and treated, disrespectfully and not find housing. So you can see these sorts of structural, interpersonal, and systemic things that can flow. And obviously, as I have said here at the bottom, there are historical and ongoing forms of trauma that affect, in particular, Indigenous peoples in Canada. And those are still active. So as long as we have the Indian Act, we will have ongoing colonial harms. So it's not just things that have happened in the past, it's the effects now, but also the ongoing active trauma that is happening. And we know, and the people that come from the sort of health and medical side, which I don't, I work in a school of nursing, but I'm not a nurse. I sort of snuck in to try to help change health systems. We know that trauma does reorganize the brain, and lots of exposure to trauma over time will actually change the physiology of the brain and body. So we become more base stem driven. It shuts off our ability to function cognitively, and we are really in a mode of keeping safe. I'm going to show you a URL to a good video. Sorry, a QR code if you'd like to take a picture on the next slide. But just to note that I've recently begun to hang around with neuroscientists, and we put in a grant proposal for a really neat project that will do brain imaging with survivors to see how trauma and the related effects of trauma are affecting cognitive function. And the cool thing is, I'm working both with community-based GBV organizations, but also a law firm. Because we had this really bad sexual assault trial in London, Ontario recently, which is where I live. And I was in the courtroom when the judge was reading her, myth-filled, horrific narrative and judgment. And the lawyers that are partnering with us were also really appalled and want better resources to train themselves and also judges around cognitive impacts of trauma. So that could be really cool if we get funded and looking using fMRI and things like that. So, well, we should find out this month if we're funded. So, situating this again back into different levels and structures, trauma responses are complex, and our ability to survive and thrive, which many people do, I think we have to keep that at the forefront. The resilience and strength come from our ability to have safe people around us, safe structures. Obviously, people will have more and less access to resources, and that's a big part of the problem and why we need this structural analysis. But from the um, impacts on your physiology, there are obviously impacts on your experiences in childhood, and those cut across the lifespan. So I also think we need to look at things like what I'm trying to call structural vicarious resilience. So instead of resilience being get that cup of tea or get the yoga room or look after yourself, how do we, as a staff or as a neighborhood or as a community or as a society, look for ways to build in that structural support? Maybe we could stop being violent towards one another, but I don't think we're quite there yet. So that those relationships of care are extremely important, and I think there are data that one caring adult and in a small person's life can make all the difference, and that caring person doesn't have to be a parent. So this video with the QR code was created by a colleague of mine at McMaster, Dr. Andrea Gonzalez, and is great. It really shows those interlinkages between what they call adverse childhood experiences and brain function and the body. So how trauma is embodied and how it affects small people. So that I would recommend watching that video. I just don't have time to show it today. So now we come to the V and adding the V. It's easy in this room because you guys all get the V. In some rooms, it takes a little bit longer to talk about the V. I think I'm speaking with the John Howard Society next week, so next week or the week after. So we'll really be hammering on that big structural V, but also the interpersonal violence across the lifespan. And that's where we start. So we really need to think about, as I mentioned before, those complex and chronic forms of trauma. And interpersonal violence is unique in this way because it breaks those relationships of trust. It makes it difficult to form attachments, and that includes to your care providers. So, again, if you're wondering, why am I not connecting with the survivor in this moment? It might not be about how great you are at opening up that space. It might be because that person has had experiences that make it really difficult for her to build those relationships of trust and to trust people. So again, time, patience, flexibility are important. If your organization doesn't give you a lot of time, that's when the moral distress can start to come in. We also know that safety is paramount. So this is why safety is such a key core aspect of a TVIC model. That everything that is happening physiologically, cognitively, is about establishing and maintaining safety. And of course, these experiences are highly gendered, and they're gendered in multiple directions. So, for example, we don't have as many services for men who experience IPV. Often they experience it from other men if they're in relationships with men. And we also have gender norms that mean that men are sanctioned if they seek certain forms of help, or really often any forms of help. So the services don't exist, and there are gender norms that are a barrier to men seeking help. I've also been working more recently with organizations that try to work with those causing harm, And I see the guilt that those folks feel in taking resources away from your sector that supports survivors. So that to me was a very new learning as I presented a presentation like this at a partner assault response conference that I think Katrina set up for me. And just another interesting form of moral distress that you feel guilty because resources are coming to you when you know there's such great need to support survivors. So that was fascinating. Just thought I would share that with you. And of course, barriers across gender and other social positionings um, happen to some people more than others. And that's where we get into the big V, structural violence, systemic violence. So these I also colloquially call the isms. And this is where you open the door to understanding how people and the way they're positioned in society sets them up either to have resources or to not have resources. So we have things like ill health directly from experiences of structural violence and racism. We know that racism kills. We've seen it in emergency departments in Canada, and with Mr. Brian Sinclair being left not because he was actually drinking, but because people had assumed he was. He never drank in his life. So the racism killed him, and that happens too frequently. And I think we need to address and acknowledge that. We also see that those experiencing GBV can also present a barrier to other social determinants of health. And I often think of women who aren't living in poverty in a relationship, but might not want to leave that relationship because their access to financial supports or safe housing are so minimal that they would rather stay in the violence or at least keep their children in at home with food and shelter than leave and take a chance on systems that are not there to support them. So again, a lot of complexity, and sometimes maybe it's easier to not deal with all that complexity, but I think we sort of have to if we're really going to unpack some of this stuff. Culturally safe care is one of those other equity oriented dimensions. And I'd like to emphasize here this is not about necessarily learning how people celebrate things or their ceremony or things like that. It is creating a culture of safety in your care interaction and in your care environment. And that should be regardless of how people who come into your service identify. And it's a culture of safety for your staff as well, so that people feel welcomed, they feel that they belong, they feel respected in those spaces. And it acknowledges those historical and collective histories and the policies and practices. And what this means is, as an organization, you have to look at your policies and practices and make sure that they're not unintentionally or, you know, intentionally reflecting some of those systemic inequities that exist. So again, as I start to show you some tools, I will emphasize we develop organizational level tools to help you look at policies, decisions that you make that impact the care encounter. So seeking authentic partnerships with those that you serve, understanding those you serve. So when we do our equip work, we usually start with a clinic or setting narrative to understand where that service organization is situated. Whose land are they on? Who are they serving? Who's coming in the door? And who's not coming in the door because of how they may or may not be providing service. So that's really helpful in understanding, how best you can make people belong in those settings. And then the concept of substance use health. And again, I was saying, Marlene, a little while ago, we are trying to shift language. And this, again, shout out to CAPSA, which is an organization of people with lived experience of substance use stigma, who has coined this term substance use health, recognizing that substance use happens on a continuum and it can be beneficial for many people. Some people don't use it all. And then there's a continuum or a spectrum along which it can become more unhealthy or harmful, according to the person themselves. So it's really, again, trying to provide care that is low barrier, understanding where people are at, meeting them there, and designing your care around those needs and experiences. We've just been doing research in London on our whole of community system response to health and homelessness, which is low barrier approach into hubs and highly supportive housing. And you get folks in regardless of their substance use. And after they've been there a while, over half of them start to use substance use treatment services. So we are showing data that even when you get people in who have no intention of stopping their use, they will if you give them stabilization around other parts of their health and well-being. Then they'll be ready to start looking at their substance use. So that's and they also use far fewer downstream services. We just published this reports on the City of London website. Actually, earlier last week, I had a fun go at City Council earlier this week. So this idea of substance use health and focusing on stigma as the harm in what's happening when people present into service settings is really an important shift, and I really encourage you to think about that. Harm reduction is one strategy along this, and again, because in our sector we talk a lot about safety as the core, and because TVIC is fundamentally about safety, I would like to shift the language of harm reduction to substance use safety. And we are developing tools and resources in that context. So harm reduction has also become a politically toxic term. And I found in the report that we just produced for the City of London and the whole of community response, I did not use the term harm reduction. We use substance use health and substance use safety. So I invite you to sort of, again, think about that. And also remember that harm reduction exists in everything that we do, all of public health. Stop signs are harm reduction, seat belts are harm reduction. We recognize that many of the things we do as soon as we get out of bed are risky, and there are ways to reduce those risks and potential harms. So again, to sort of bring it back to that level of understanding and neutralizing some of the language that can be harmful, and really be a barrier to good decision making. I find these days, especially with the term harm reduction. So, how does this apply to the gender-based violence sector? And I do have to say, I was so delighted when Public Health Agency of Canada had a call for proposals in this area because I've been working for almost 3 decades on gender-based violence and especially trying to support the sector, but also get the health sector to do a better job. And separately on the equip work and TVIC and equity oriented care. And this was the opportunity to bring it together. So, like, got 3 years till I retire. I'm doing this. I'm very, very excited about this. Two forms of evidence support from sort of a research perspective why this is important. So this is a paper, and again, anything you see here, if the QR codes don't work, my email address is at the end. Just flip me an email. I will send you any of these and links to all these resources. But my colleague Tara Mantler and I did a review of systematic reviews on what's effective in terms of IPV interventions across the spectrum, from primary prevention through to identification and initial response, through to secondary and tertiary prevention. And basically, and also interventions to support couples and those using violence in relationships. Basically, those that embed this more structural TVIC equity promoting lens. So, for example, the Duluth model, when you're working with men using violence, are the ones that show the most effect. So there is an evidence imperative around this as well, to have that lens, to understand those root causes instead of bringing everything down to an individual level and saying, well, he just snapped or he's got mental health problems or, right? That it is that sort of critical understanding of those structural root causes. And at the same time, because Katrina and I, either we're both brilliant together or fools seldom differ, whichever, Katrina and Angelique wrote a paper similarly looking at how we embed TVIC into supports for those using violence in relationships and found similar results. That these are really important considerations. So we did this work independently, published it in the same year, and came to very similar conclusions. I think there's good momentum to start to orient interventions and to convince our funders and policy folks that this is the way we need to be doing things. So, with funding from Public Health Agency of Canada, colleagues at UBC and UNB and those at Western University in London are working to equip the gender-based violence sector for equity. So we've done needs assessment and interviews with those providing direct service to survivors, with leaders. We've worked with a number of organizations listed here, a couple out west, several in London, including the Muslim Resource Center, because we're very concerned about how newcomer women get care and services around their entry into Canadian society. We've worked with ANOVA, which is one of the largest sexual assault and gender-based violence, domestic violence centers in Ontario, London Abused Women's Center, and as I mentioned, Changing Ways. So from this work, we know that all three key dimensions are very important according to those who are providing service. But TVIC has a particular role because the V is that door in. And it's often the one that resonates with people who are doing work in the sector already. And then you can bring, I sometimes have the image of a Trojan horse. You can bring in the other things that might be a little more sticky or difficult through that big V, through that trauma and violence informed door. And really, they felt that the sector needed to take this on. That was a key message that this evolution sort of has to happen. And issues of substance use, mental health, and other forms of stigma and discrimination are extremely prevalent. They often are the thing that leads to a decision for a woman to get a shelter bed, which are always at overcapacity, as we know, or not. So the impacts of those implicit biases that people might carry in the moment can be extremely harmful for clients when they're seeking care. It's almost like, does she deserve care if she's using substances or if she's in an acute mental health situation? And that usually gets translated in, well, having her here won't be safe for the kids who are on site. And again, what does safe mean in that context? Is it about your comfort or disruption, or is it actually about safety? These are hard thoughts to have and hard reflections to do for sure. I live in downtown London. We've had a huge increase in homelessness and street level sleeping, people sleeping rough on the street. And sometimes people are in acute distress and they're ranting on the street. And you can be like, I'm never going downtown again. Or you can say, perhaps we can support this guy, get him over to one of the drop ins for a cup of coffee, right? That's a decision that you can make. So I do try to demystify and unpack what we mean by safety when it often means discomfort, because we know in some ways we're complicit with not solving this problem. So, how does equity oriented care through, again, that TVIC door become a core practice orientation? Well, we know that people who have experienced GBV have a much greater likelihood of chronic pain, poor mental health, and unhealthy substance use. People with chronic pain are more likely to use substances in harmful ways. GBV has cumulative effects on mental health and substance use health, as well as on physical health. And again, if we look at impacts on sleeping, on chronic pain, it is all sort of a complex, interwoven messiness of feeling extremely unwell and it being really difficult to make decisions. When we add in things like brain injuries from strangulation and blows to the head, you can also see how those effects might influence the ability to make decisions for next steps. And again, weaving in those experiences of structural violence will compound those negative effects. So we see how these three key dimensions really play in and intermix. When we think about substance use specifically, often, and again, some of these sort of myths and misunderstandings that we need to demystify a little bit. Substance use is often seen as causing gender based violence. Following this, it's used to exonerate perpetration. So, he had too much to drink. That was certainly the hockey player excuse that she had had too much to drink. Everybody had too much to drink. It's constructed as increasing vulnerability to survivors, so therefore they're blamed for having put themselves in a situation where they are experiencing violence, and it can be used as a form of coercion. So we often see that in terms of keeping women in relationships by ensuring that you're their only supplier of substances and things like that, which then can play out in risky things when she does seek help and she's at a shelter, a second stage. And I heard this as a case from one of our service partners, and he's her supplier. So she can't really get away from him. He knows where she is. That increases the risk. So, how do we untie those really difficult knots? This is a diagram I'm not going to go over, but it basically shows that it is the intertwining of stigma that causes a lot of the harm. Thankfully, we have a whole free e learning module at this QR code called the Nexus module that unpacks these things, that really gets you understanding the linkages between chronic pain, experiences of gender based and other forms of violence and trauma, and substance use, and where the stigma is doing the harm. So I invite you to have a look at that learning module if this is of interest to you. So when we get from trauma informed to trauma and violence informed, it's really addressing those systemic and structural forms of violence and making those a core feature of how you think about how that person is presenting in your service and how you're designing your service to be responsive to both what's happened in the past, but importantly, to what might still be happening in that person's life. And to really frame some of the downstream consequences for that person, for your client, such as unhealthy substance use, as anticipatable. That it's something that your organization and you as a provider should be prepared to deal with if you really are providing equity oriented care and ensuring that people are safe when they come to you. And again, moving to this more structural lens gets away from thinking about people as having something wrong in their heads and thinking more about what's happened and is still happening in their lives. And again, that's an important cognitive switch for us because it leads us to empathy and away from judgment, which is another sort of core path that we're trying to walk with TVIC. And really, in this space, acknowledging those complexities and the chronicity of the trauma and its ongoing effects and those broken relationships of trust and care and how difficult it can be to form attachments. So the 4 TVIC principles are quite simple. As I said, they're very adaptable to different settings and contexts. We've even used them with policing services, right, Margaret? And it's really bringing in those the key principles that we've seen in other models of TIC. Sometimes they're up to 10 different principles. We've tried to simplify them to 4, and in fact, some of our work and some of the curricula I develop, I combine 3 and 4 because they're related in terms of providing spaces of trust and collaboration and person or woman led decision making, but also building on her strengths and your strengths as a provider as well. So always seeing that work as relational and what you as a provider are bringing into it, both good and maybe less good, but being aware of that and making sure it's sort of to check those things. And that active work to counter stigma and discrimination and other forms of oppression, whether it's substance use stigma, mental health stigma, racism, ableism, whatever it is, actively counter it in your organization and support your providers in countering it in their practice, which might mean giving people a bit more time in those interactions if it's needed and really relying on professional judgment to make those calls because often that is happening in the moment as someone comes in an emergency situation, for example, in a crisis shelter, and you need to make those judgment calls in the moment. So the organization has to give the freedom and flexibility. And I would say also the education underneath that, certainly in HR and onboarding practices, to be able to do that. This is the book. I did want to point out that the chapter that Margaret led on bringing systems together through a TVIC lens. In this case, it was the sector that supports, anti-elder abuse or abuse of older persons with the IPV service sector, and that was several people have said it's their favorite chapter. So highly recommend that one. And of course, we'll all retire on the royalties if you all buy the book. Not. So how do you get started on this stuff? And again, I think this will resonate with most, many, all of you. It starts with the way you think about people and about your interactions with people. So instead of, they're making this up, this is hard to hear and talk about. We've obviously moved the language from victim to survivor. She can't cope. Well, she's actually coped all the way up to this point when she's with me in this interaction. So how has she done that? Let's ask her how she's done that and build on that strength. So that is a TVIC approach. So the thinking is important because it can start to offset those implicit biases that you might not know are there. And then the language. Language is so hugely important, as I mentioned. And again, people can call themselves whatever they want. I have utmost respect, and I've worked with folks who they call themselves addicts or junkies. That is their decision. But that would not be a TVIC way to refer to a client or patient or survivor in your care. So, person first language, obviously, recognizing that this is a moment in somebody's life and often not their best moment, frankly, when they're there to see you or they're in their emergency department or et cetera, et cetera. And this, if they're at this moment experiencing homelessness, they might not be in the future. So, we have to have hope that they won't be experiencing homelessness in the future. So they're not a homeless person or a person experiencing homelessness. And that respects their autonomy. So when they choose not to follow your advice, that is not them being non-compliant or non-adherent. That is them making their own decision because they have agency, and supporting that agency and not seeing it as a power struggle. So it's sort of the power with over power over approach to care, and want to normalize and reframe, and always validate people's experiences. So this is obviously starts with believing survivors. Believing survivors doesn't mean that you're prosecuting the case. It means that in that moment you are listening to her and you're validating and you're believing what she says. Okay? It's not a court of law in that moment. And again, strengths based and future oriented. So this is important both in those interactions, but also when you're talking about clients, when you're doing a handover, a shift change, when you're documenting, because you don't want stigmatizing language to follow a client throughout their record. And this happens in a terrible way in healthcare, drug seeking. If that is on your chart, anywhere you go in the system is going to start with a really stigmatized, judgmental, horrible interaction for that person. So how you document is also really important in thinking through that TVIC lens. So we've mapped this on to, in this case, the lives response from the World Health Organization from the clinical handbook for working with women who have experienced partner violence. So lives, listen, inquire, validate, enhance safety, provide support, um, maps on very nicely with the TVIC principles and can be articulated in some of the quotes below. Is it safe for you to go home today? Instead of a screening checklist that asks a whole bunch of horrible questions to every woman, regardless of why she's there, you can look for clinical signs or signs and indicators of abuse and say, I'm concerned about your safety today. Is everything okay at home? That is a much more trauma and violence informed way to open up a space for her to decide whether or not she wants to disclose. It is her decision than you forcing that decision on her because of your needs or the system's needs with a brutal checklist asking if she's been, sexually assaulted, raped, strangled, etc. So I feel very passionately about that. You saw me get a little worked up there. Many of these things serve the system's needs, not the survivor's needs. We know that. I see lots of nodding of heads. And there are ways that organizations, thank you, can reframe, especially at intake, how that happens to set up that woman for success in your service, whether it's a shelter stay or some counseling over a while. This is really neat. So this comes from my colleague Holly Meany at Changing Ways, who is trying to find TVIC ways in working with men, especially when they're resistant. And I say men because they predominantly are the ones who are mandated to these partner assault response programs that Changing Ways offers, but people using harm in relationships. So reframing the resistance that you see and understanding that the resistance can come from different places. It can come from, just an active, I didn't do it. She's the problem. This is not about me. I shouldn't be here. So extremely resistant, and you're not really probably going to move them very far to their own trauma response. And for Holly and the folks at Changing Ways, it's really always about balancing accountability with understanding and never eluding the accountability because people do make decisions to act in certain ways. So we are actually through this project, an extra deliverable, Shannon doesn't know about yet, is a new separate curriculum for that sector. I was really surprised, along with the guilt that they feel about taking resources, they don't have a lot of supports for onboarding new staff. With our GBV curriculum, like for this survivor support sector that I'm going to show you in a moment, Katrina, and Krivac offer a whole range of online courses that are available. So we're going to link to that. We don't have to go over, GBV 101 because there's lots of material on that via weducation.ca, like lots of material out there. Not the same on the perpetrator support side. So we are creating that curriculum with the sector. And that's very exciting work actually to bring that TVIC lens. These are a couple of the tools that we have developed. The top one is an adaptation of a previous tool we'd created for, outside of the sector. But this one really gets into what it looks like to do a trauma review or a walkthrough to see how your services are experienced by people as welcoming and safe and inclusive or not. And it sort of brings in like the first time a woman walks into a shelter, for example, what is she experiencing? Is she experiencing the double secure doors as safety, or as, wow, this feels like jail. And just sort of talking through that as a staff, and then maybe asking what a woman feels when that happens, when she walks into shelter, or what a kiddo feels. Remember the first time I brought my then 11-year-old daughter into a shelter to do oh, to do cupcake decorating with the staff. She said, "Wow, this is really scary, like the big clicking double doors and things like that." So how do kids experience that? The second one is a tool to help with discussions about substance use in the context of gender-based violence. So that one is ready. It's posted at the both of those are ready and posted at those QR codes. There's the free education that Katrina mentioned earlier. So this is what we call foundations. This is across different sectors: health, social services, homelessness shelters. It's got examples from a whole bunch of different people who work in different fields, but also in different contexts. And the cases are pretty broad and broadly applicable. It's about 7 or 8 hours. There's a certificate of completion. I think we're at about 9,000 people who have taken it across Canada now. This is the new one that hopefully will be done by Christmas if I can stop doing health and homelessness work for a little while. And these are some beautiful illustrations by our illustrator, Matt Evans, who helps us with the cases and to bring those cases to life. So that will be the module that is linked through Prevac's site to some of the existing courses that are online, and then ideally also the one to support those working with men using violence. This is a document we created a number of years ago and then updated recently to really embed the TVIC lens. I found this document extremely useful with journalists, for example, who don't understand, well, why doesn't she just leave? Why didn't they just report? Why didn't they just tell anybody? And this sort of walks through what we know from qualitative research on how difficult it is to even come to the realization that you're in an abusive relationship, to actually put that label on yourself. Um, and then, what it looks like as a provider to provide that TVIC response and what the woman might be thinking. So again, this is drawn from qualitative work and presented in a way that we hope is a little bit more, understandable in non-academic contexts. And I mentioned earlier iHeal, so this is the iHeal app, French and English, freely available across Canada with links to provincial level resources. It is founded on TVIC and equity-oriented principles, and a very good companion for your service to women as well, especially if they're on a wait list because your services are overbooked. So why is TVIC, in my view, essential for gender-based violence services? It's effective. So we know that from the research evidence. It brings in that explicit equity lens and ensures that we are making spaces safe and inclusive for all women and survivors, regardless of where they come from or what their past experiences have been. And it's based on safety, empathy, and respect, and not judgment, and really bringing in those values, but also for the provider, as I started with today. It is about making sure that you are safe in your work and you are fulfilled and you are respected through pay equity and things like that as well. Because if you're not, you won't be there, and then we don't have a support sector. So I often leave something like this as a reflection just for you to think about, or if you'd like to start a discussion with your own reflection. How could it help you in your work, whatever that might be, whether it's direct service, supervision, management, leadership, or policy, and what one thing would you do to start? There are resources. That's it.
Thank you so very much, Nadine. You know, I'm just always in awe. So, and there were so many things in there and so many different resources. The thing that's sitting most with me is this idea of structural vicarious resilience. Although I kind of really liked structures of relationships and care. Is really thinking about how do we create those structures for ourselves, the people we work with, in our organizations, for the people that we serve, so that everybody feels that. Because when we feel cared for, it's easier for others. We have time for maybe 2 questions or reflections, things that you want. Yeah. I s- Wait 1 second. We need to do it. The mics are very important also for people, in
Yeah.
translation.
Hi there. My name is Megan Perlano. I'm a PhD student at Western University. I work with Dr. Caitlin Mendez. And my question was, I just wanted to piggyback off of Katrina's um, language. I just wanted to check, was it structurally informed resilience or structural vicarious
I
resilience?
kind of like structural vicarious resilience because it brings in the idea that we grieve as a team, but we support each other as a team or as a community. So you're not left alone to do it. I think that's what always concerns me about the idea of resilience without that framing is that you're left to go be resilient by yourself, right? And so I'm toying with the idea of structural vicarious resilience. And again, this does come from I remember speaking with some direct service providers at a community health center during COVID. And because of the COVID restrictions, they weren't able to get together to grieve the deaths of their clients, often in outreach who were living rough and had overdosed. And that grieving process is so important. Actually, we have tools on supporting provider well-being, as I showed you at the beginning. One is individual practice, but another is a discussion tool for the organization to rate your organization and start talking about this and we have a piece in there on grief. And it's because, those of us who have been speaking with folks who are doing the direct work are hearing about that coming together to support each other to get through their own trauma that they're experiencing. Does that answer it, Megan? Yeah. No. I think that's one of the next things. I mentioned I have a doctoral student who's looking at doing a big systematic review right now about what organizational interventions exist around these threats to provider well-being, and then we'll start speaking with providers who are doing direct service with IPV survivors through our regional domestic violence treatment program, and also probably through our shelters and GBV organizations locally, and then start to model what an intervention might look like and I think that's where we can start to embed it and look at how it works.
What that means is that you heard it here first.
You heard it first.
It's not there yet, but we're like, one more, yeah? Oh,
OK, OK. C'est bien?
Okay. I'll be speaking in French. Can you hear the interpreting? Checking the English. Okay.
Merci, j'aime bien
Thank you.
ces recherches.
Thank you. It's very interesting to hear about all this research and what it leads us to. But
Personnel
here's my personal reaction as a survivor
des pensionnats.
of the residential schools.
Le mot
The word resilience
pour moi d'accepter.
has always been a very difficult term for me. It's very hard for me to accept the term of survivor. And the word resilience
Qui résonnait en moi, mais
really does speak to me, but it's
c'est comme si ça me
one point or another. To me, resilience is also being pulled back to that survival mode.
avec
And the word
je me sens
that
justement un peu sortie des traumatismes.
has helped me get out of trauma, that intergenerational trauma, I must say, has been something I have really struggled with.
Qu'est-ce que j'avais en dedans? Puis
And
aussi,
today, the word that really speaks to me and that gives me a lot of hope
quand je vois aussi chez moi
when I
toutes ces
see at home all these people who are still struggling with multiple trauma in their own history, that word is resurgency. That's the word that speaks most to me, Miigwech. Thank you.
Thank you so much for your comment. Resurgency is a wonderful, wonderful word. Structural vicarious resurgency. Does that work? I like it. I heard somebody said, mm-hmm. Thank you so much for sharing that and for sharing your experience.
Thank you. Thank you, everybody. Um, again, Nadine, I really, really appreciate your thoughts and reflections. I'm going to do a little bit of advertising now. My marketing for the next little part, a little bit of a set of where we're going. So now we're going to have break in this room. We're going to be talking about the Astra program, which is a perinatal program, followed by an art and story program offered by Art de Conte project. International A is back to our kind of mini presentation, so there'll be a whole bunch of things, happening there. In Paris, we're moving more into the IPV and substance use space. And today, later in the London room, we're going to be talking about there's a series of presentations, a lot around arts-based expressions with newcomers, and also a bit on traumatic brain injury. And then finally, in the New York room, there are 2 workshops about engaging Black men as leaders in domestic violence prevention. And so I'm just so thrilled that there's such a range of things here and such a wealth of knowledge and experience and thought about how to put these trauma and violence informed principles into practice. I also am just going to do one final announcement, and that is, CREVAC has been. If you are not, please join our mailing lists and find out what we're doing. We really are honored to be able to highlight and profile the work of people across the country and the province. And then once a year, we have been trying to do kind of a sort of a really special event in honor of Peter Jaffe, who was the director of CREVAC for many years. So we run the Jaffe lectures, and this year's Jaffe lecture, and in that we try to bring in somebody that is maybe international whom we don't hear from as often. And, in all of what we were just thinking about trauma and violence informed spaces, I keep thinking about the fact that I have teenagers, and a lot of their space is an online space. And I've been really inspired by some of the conversations that I've heard in younger people, also in older people, but in younger people, about what does a safe online community look like? What is care and connection? What is equity? What is trauma and violence informed in an online space? Well, it's not, anyways, what is that? And what do we need to do to create those kinds of structures? So this year, because of the way the world is right now, this year we actually invited an American colleague, Cynthia Miller Idris, who runs something called Pearl, and I just a polarization and extremism research and innovation lab. That's what it stands for. And so she's going to be doing a lecture on gender-based violence and violence extremism. So you can find some information online about that. It will be live streamed for people who want to join. And if you wish to make the trip to London, it will be an in-person as well lecture with her. So thank you. Please enjoy your break and enjoy the rest of the day. We'll see you later this afternoon.